Neurology Rapid Review, Guillain Barre Syndrome. AIDP is the most common form of GBS and accounts for 90% of the cases. It is an acute and monophasic polyradiculoneuropathy. The mean age of onset is 40, but no age is exempt. 70% of patients report a respiratory illness or gastroenteritis 2 to 3 weeks before onset of weakness. Campylobacter jejuni is the most common organism associated with GBS. Other infections include CMV, EBV, influenza A, and enterovirus, as well as Mycoplasma pneumoniae, H. influenzae, Zika virus, and more recently COVID-19. It begins with symmetric and usually ascending weakness. Severe radicular and neuropathic pain occurs especially in the lumbar region in 70% of the cases. Weakness is the predominant feature and is both distal and proximal, in contrast to other neuropathies with hypo or areflexia. Objective sensory loss is mild. Facial nerves are involved in 50% of the cases with facial weakness. Oropharyngeal weakness occurs in 40% and ophthalmoplegia or ptosis in 10%. 50% reach weakness nadir by 2 weeks, 80% by 3 weeks, and almost all have completed progression by 4 weeks. Weakness ranges from mild weakness to flaccid quadriplegia, and up to 1/3 progress to respiratory failure. Dysautonomia can occur. This most commonly manifests as sinus tachycardia, and that is seen in 70% of the cases, but severe autonomic dysfunction may be seen. Pathogenesis. GBS is due to an autoimmune response that targets peripheral nerve myelin. To put it in a simplified form, immune responses that are directed against antigens of infectious agents like Campylobacter jejuni result in antibodies, and these cross-react with gangliosides of peripheral nerve myelin, resulting in damage to the peripheral nervous system. This process has been termed molecular mimicry. T-cell infiltration and macrophage-associated segmental demyelination occurs at the nerve roots and proximal nerves. If damage is confined to myelin, there is a good prognosis for recovery, as myelin in the peripheral nervous system regenerates in a few months. However, severe inflammation can cause axonal loss, and prognosis for recovery is much worse, as axonal regeneration is slow and incomplete. Differential diagnosis for GBS is broad and includes both peripheral and central conditions that can present with acute muscle weakness. To name some of these conditions, diseases in the peripheral nervous system include neuromuscular junction diseases such as myasthenia gravis, botulism, and tic paralysis, muscle diseases such as inflammatory myopathies, periodic paralyses, rhabdomyolysis, and electrolyte disturbances such as severe hypokalemia, interior horn cell diseases such as poliomyelitis or West Nile virus, diseases of the roots and peripheral nerves such as infiltration by lymphoma or leptomeningeal carcinomatosis, toxic neuropathies due to solvents or heavy metals, porphyria, Lyme disease, and HIV. And the major differential diagnosis in the central nervous system is acute myelopathy, both compressive and non-compressive. Investigations. CSF examination. The CSF shows high proteins without WBC elevation, that is less than 20 cells per millimeter cubed, in 90% of the cases. This is called albuminocytologic dissociation. However, these changes may be delayed up to a week. Gliocytosis should raise suspicion for infections such as HIV, CMV, and Lyme disease, and also for other conditions such as sarcoidosis or carcinomatous meningitis. Electrodiagnosis. In the first few days, nerve conduction studies may be normal or show only subtle changes like prolonged or absent F waves and H reflexes, and a patchy increase in distal nerve latencies. As the disease progresses, typical features of a demyelinating neuropathy, such as conduction block, temporal dispersion, and prolonged distal and F wave latencies, are seen, but slowing of nerve conduction velocities may occur late. The commonly used criteria for diagnosing Guillain Barre syndrome are the modified Asbury criteria. These are as under: required progressive weakness of more than one limb with hypo or areflexia, supportive progression less than 4 weeks, symmetric weakness, cranial nerves especially seventh nerve affected, autonomic dysfunction, high CSF protein and cells less than 20 per millimeter cubed, EMG and nerve conduction study suggestive of demyelination, features that cast doubt on the diagnosis, marked asymmetry, onset with or persistence of bladder and bowel dysfunction, 50 or more lymphocytes per millimeter cubed in the CSF, polymorphonuclear leukocytes in the CSF, and a sensory level. Conditions to be excluded are causes such as toxins, botulism, diphtheria, porphyria. Treatment: plasma exchange. Plasma exchange removes autoantibodies, immune complexes, and complement. The total exchange volume is 250 ml per kilogram divided over 5 alternating days. Complications of plasma exchange include hypotension, cardiac arrhythmias, allergic reaction to albumin replacement, hypocalcemia, anemia, and thrombocytopenia. Plasma exchange reduces the time to walk unaided by 30 to 40 days and time spent on a ventilator by 2 weeks. Intravenous immunoglobulin. IVIG is a pooled donor immunoglobulin and results in a substantial increase in serum immunoglobulin G that normalizes by 3 to 4 weeks. Adverse events include mild infusion-related symptoms such as nausea, fever, chills, and headache, as well as aseptic meningitis, rash, rarely severe anaphylaxis, and renal failure. IVIG and plasma exchange are equally effective, but IVIG is usually preferred since it is easier to administer. Plasma exchange followed by IVIG is not more effective than either therapy alone. Oral and intravenous steroids have not been shown to be effective in the treatment of GBS, either alone or in combination with IVIG or plasma exchange. Treatment of GBS also requires comprehensive supportive care. Patients must be monitored for respiratory failure with Q4 measurements of respiratory function, such as forced vital capacity and negative inspiratory force. Patients should be transferred to the ICU if these parameters are declining and there is a high probability for respiratory failure. Other management required is treatment of cardiac arrhythmias, dysphagia, paralytic ileus, hypotension or hypertension due to autonomic neuropathy. Pain is managed using medications for neuropathic pain such as gabapentin. Early PT and OT are advisable to maintain range of motion, to prevent contractures and begin the rehabilitation process. Prognosis. Most patients show good to excellent recovery and 80% experience full recovery or only minor deficits. Some patients do not regain full strength in the hands and feet, and residual bilateral foot drop requiring AFOs is not uncommon. Numbness, pain, and persistent fatigue are common residual symptoms. Most of the improvement occurs within the first year, but improvement can be seen for up to 3 years or longer. Mortality is 3 to 7% and is due to respiratory failure, infection, as well as severe autonomic dysfunction. Poor prognostic factors are old age, rapid progression of weakness, that is, nadir reached in less than 7 days, mechanical ventilation required, preceding diarrhea or Campylobacter jejuni infection, severely reduced distal amplitude of the motor nerves on EMG and nerve conduction studies. GBS variants, axonal variants. Unlike AIDP, where segmental demyelination is typical, in these axonal variants, axonal degeneration is prominent with a worse prognosis. Acute motor axonal neuropathy, or AMAN, accounts for 5% of GBS cases. It is most commonly reported in China but can occur in any geographic area. Like GBS, it is triggered by an infection, most commonly by Campylobacter jejuni diarrhea. Anti-GM1 and GD1A antibodies cause axonal degeneration of the motor nerves. It presents as a rapidly progressive extremity weakness, reaching a nadir within 4 weeks or quicker. EMG and nerve conduction studies reflect axonal injury to motor nerves with reduced amplitudes of the motor nerves, normal latencies in conduction velocity, and normal sensory studies associated with the neurogenic EMG. Acute motor axonal and sensory neuropathy, or AMSAN. This has sensory in addition to motor involvement and is rarer than AMAN. Antibodies against GD1A, GM1B, and GM1 are implicated in the pathogenesis, and axonal injury of the dorsal and ventral roots explains the clinical features. Treatment with IVIG administered within 2 weeks of symptoms has evidence of efficacy in axonal GBS. However, in spite of treatment, axonal dysfunction is a poor prognostic factor, and most patients with AMSAN and AMAN have poor long-term outcomes with severe disability. Other GBS variants include the Miller-Fisher syndrome, which consists of a triad of ophthalmoplegia, areflexia, and ataxia, and some patients may also have facial and pharyngeal weakness. The anti-GQ1 antibody is found in 90% of these cases. The GQ1B antigen is expressed in the oculomotor nerves and in the muscle spindles and accounts for the clinical features. CSF may show albuminocytological dissociation. The motor and sensory nerve conduction studies are often normal, but H reflexes are absent in 75%, reflecting loss of ankle reflexes. The prognosis is good, and patients may experience improvement in 1 to 2 months and make a complete recovery within 6 months. IVIG and plasma exchange have been used for treatment based on their efficacy in GBS. Thank you for watching.